Welcome to OsteoBites, everybody. My name is Anne Graham. I'm an OsteoWarrior and executive director of MIB Agents. It's a gorgeous summer day. It's still light outside, even though it's 6 o'clock at night. We're getting together later than our usual snack time, so I only have coffee, which is entirely appropriate because we all get to listen, drink our coffee, and talk with a great human, doctor and friend, Dr. Moyez Jiwa, otherwise known as Please Call Me Moyez. Dr. Jiwa is wholly dedicated to his patients and is one of the best listeners you could ever hope to speak with. He wrote this book. Before I show it to you, I should explain. It came to me like this. And I've also highlighted and dog-eared it. It's called The Art of Doctoring, which I hope doctors and hopeful doctors everywhere will pick up. It's really, it's a great read. I have no intention of being a doctor, and I really enjoyed it. I think it makes you a better listener. Dr. Jiwa is a practicing general practitioner. He's editor-in-chief of the Journal of Health Design and an associate dean and professor at the Melbourne Clinical School at the University of Notre Dame. Before we get rolling on the art of doctoring, I need to tell you about the many individuals who are vaccinated, who have teams who are getting together in real life to outrun, outwalk, or outpedal osteosarcoma, including Dr. Matteo Trucco, who I'm guessing, Mia, you named your cat after Matteo, just wondering.
How did you know?
Dr. Trucco and Dr. Pete and the Cleveland Clinic put together the Cleveland Clinic Solid Squad, and I'm not kidding, they're the biggest medical team on our roster. You and your team can participate anytime from now through August 31st with a 5K, a half marathon, a full marathon, or a combination. Treadmills, Pelotons, all welcome too. We are super grateful for the sponsorship of BTG Specialty Pharmaceuticals. If you would like to join or create a team, you can go to mibagents.org/outrunning. You get some serious swag. This is it for registering, including the must-have t-shirt, style of the season right there in our regular best t-shirt ever, comfort. It's beautiful. It's lovely. You just want to live in it. The links will be shared on this podcast and on YouTube. And I would just go to the website, mibagents.org/outrunning. Dr. Jiwa, would you start the introductions, please?
Thank you very much, Anne. My name is Moyez Jiwa. I'm a family physician above all else, despite all the other things that you talked about. But I'm also happen to be the editor of the Journal of Health Design and the host of the Health Design podcast. And that's as much as I want to say, because I'm going to tell you all about myself in the presentation. Thank you, Anne.
Hi, everyone. I'm Mia. I have been battling osteosarcoma for almost 3 years now. I'm a proud junior board member, and I'm an incoming junior at the University of California, Santa Barbara, as a psychological and brain sciences major. And I'm really happy to be here today.
Hi, everyone. My name is Maeve. I am a 2-time osteosarcoma survivor, now 6 years, no evidence of disease. I am a rising senior at Northeastern University in Boston, studying health science on a pre-med track. And I'm also honored to serve as the MIB Junior Board President. Thank you for having me today. I'm very excited.
All right. Thank you very much. It's a great honor to be here, and thank you so much for inviting me to do this presentation. And I want to start from the years 1981 to 1987. And the reason that those years are most significant for me is that's the year that I went to medical school. And what you see in the picture is a cassette. Now, these days, you cannot buy a cassette player, certainly not in Australia. So it goes to show you how much the world has changed since the day that I went to medical school. That would be like saying that in another 30 years, when you're in practice, if you happen to be wanting to be a physician, that Spotify and Apple Music will seem so passé. Well, cassettes are so passé. I think the Walkman was introduced while I was in medical school. So this is Trinity College Dublin, where I went to medical school. And this is taken around about the time I went there. The thing about it is that you'll notice there are bicycles on the front lawn. Now, I don't know why we parked our bicycles on the front lawn, because they regularly got stolen. I reckon I lost about 3 bicycles from the front lawn of Trinity College Dublin. The year I went to medical school, Dolly Parton was belting out 9 to 5. Muhammad Ali retired. John McEnroe was making quite an impression of himself as an American, shouting, "You cannot be serious," on the lawns of Wimbledon. And Charles and Diana were married. The 1980s were a very interesting decade to be in medicine. That was the decade when we saw the rise in the number of doctors. So the number of doctors doubled from 1971 to 2001. And I remember many medical schools being set up in and around the 80s and 90s. Smallpox was eradicated just before I went to med school. There was a vaccine for hepatitis B. And Australians discovered the role of H. pylori, which, as you know, is a cause of peptic ulcers, which dramatically changed, certainly my career. In the 1980s, when I was on the surgical rotations, we spent most of our time learning about surgery for peptic ulcers, which in fact was completely passé, as it were, when they discovered the role of H. pylori and the ability to eradicate that. The HIV virus was discovered, and there was a little thing in 1983 where they discovered the birth, or we had the birth of the internet of all things. The year I qualified, 1987, President Reagan was telling Mr. Gorbachev to tear down this wall. The Simpsons first appeared, and you can see there some of the details about life in America, the average cost of a new house, the average income per year, a gallon of gas, petrol in this part of the world was 89 cents, a pound of bacon was $1.80, and the US postage stamp was 24 cents. A dozen eggs cost 65 cents. That'll mean a lot more to you in America than it does to us, but it sounds quite cheap, to be honest. So when I left medical school, I was given 3 gifts and something else. And the 3 gifts were these. I was given a fantastic education. You have to remember that I had gone to medical school in 1981, having arrived in the Republic of Ireland from East Africa in 1975. So within 6 years, I was at med school, and in another 6 years, I was out in the world carrying a stethoscope. And the Republic of Ireland had given me 3 gifts. She had given me a fantastic education. By that time, she'd given me one of her daughters and said, go out there and conquer the world. Her name's Bernadette. Bernadette Jiwa, by the way, is who I'm married to. And she gave me this amazing accent, which totally confuses people when they see me on screen. They do wonder what this is all about, and it is an Irish accent. But there was one other thing that I got from medical school, and this is it. In my first job, my very first job, in the first 3 months of my first job, I published a paper with Professor Harrison, who was then my boss, on the psychosocial pressures on women attending for infertility investigation. And the paper was focused on the role of the junior doctor. And that paper has more or less been my flag for the past 30 years in practice, because it started with a conversation with a nurse about why these women were so upset at the end of Professor Harrison's ward round when he told them that they couldn't have babies because they had endometriosis or some other problem. And my job was to go around and speak to those women afterwards, explain what he had just said, and understand why they were so upset and get some help for them. And essentially, it was about seeing them in the context of their lives. So, Republic of Ireland, 1987, very Catholic country. These women were coming in with 9 siblings each, 30-something nieces and nephews. And you can imagine the pressure on these women to procreate. And that paper and the focus of that paper was something that I carried through the rest of my career. So what happened next? Well, this is what happened. In 1987, 1980, when I went to med school, 12.7% of Americans were obese. And it is estimated that that number is double now and will continue to rise to the point where we will have half the population who will be obese by 2030. And here are some other facts since I left medical school. Now 90% of every health dollar goes on treating people with chronic conditions. And these are not infectious diseases, these are lifestyle-related conditions. 40% of US adults have more than 2 chronic conditions. 47% of the total cost of chronic disease is related to obesity. And the national per capita average total cost of chronic illness is $11,201. It is a huge increase in costs. And then we look at the prevalence of cancer in the population. And you can see from this slide, going back to 1980, the proportion of people where cancer is prevalent is increasing in every single age band. It's increasing dramatically. The incidence and prevalence of cancer is increasing. And then you look at the time with the primary care practitioner. And you can see that this hasn't changed very much even since the 1980s. So if you're in India or in the UK, you get less than 10 minutes every time you go to see your primary care practitioner. The primary care practitioner is the first person you see with any illness. In the US, it's a little bit more generous, and in Sweden, it's even more generous. In Australia, we are somewhere in the middle, about 15 minutes. When I go to practice in an hour's time, I will have 15 minutes with each of my patients, 15 minutes in which to deal with their multi-morbidities, their chronic illnesses, which, as I say, has increased. So there's a huge pressure on the time available. And then, of course, there's the whole issue of the cost of all of this healthcare. And we're currently spending in the US 19% of GDP on healthcare, and that is set to increase even further. But at the same time, the complaints against doctors continue to rise, and it's very interesting where those complaints are focused. So these are the most common NHS, this is a British data, but it would apply anywhere in the world, most common NHS complaints. And you can see that the number one cause of complaints against doctors is communication. Incredible that for all of our increasing use of technology, for all the advances of science, the discovery of HIV virus, the discovery of all those things that I told you about, the eradication of some nasty infectious diseases, the increased improvements in the treatments of diabetes and whatever else, communication is the number one reason why people write letters of complaints about doctors. And if you go down the list, I mean, simple things like nutrition and hydration. Number 4 is of interest. The values and behaviors of staff is a cause of complaints today, even far more than appointments, delays, and cancellations. And then when things go horribly wrong, these are the kind of reasons that people give for a medical accident. Receiving a diagnosis that doesn't make sense. 42% of those who have a medical misadventure have this as their cause. The diagnosis didn't make sense. 39% of people say they were not treated with respect. And that pales the other reasons into insignificance, going down the way until you get to the point where having the wrong drug is very much, and it's not even on the slide, is not a huge reason why things go wrong. Things go wrong because people are not treated with respect, because we fail to communicate, and because things go wrong when humans interact with one another. And then this is the other thing that happened since I qualified, and that is physician burnout became a real thing. In 1987, when I was a junior doctor, I would start work on Saturday morning and I would finish work on Monday night. And that was one weekend in 3, one weekend in 4. And when I was on call during the week, you would start work at 9 in the morning and you would finish work the following afternoon. It was almost regarded as a requirement for you to work those hours in order to get the experience that you needed to treat patients. Quite frankly, that was unsustainable. And it continued in the early part of my career, same kind of hours. So these are the dimensions of burnout: feeling overwhelming exhaustion, feeling cynical about your job, and a sense of ineffectiveness and lack of accomplishment that dogs doctors today. 44% of physicians in 2017, according to a Mayo Clinic study, had at least one symptom of burnout. And that continues at that kind of level for decades afterwards. So in 2021, to go back to 1987, looking back, we are sicker. We're likely to become sicker because of the lifestyles that we have. We pay more for healthcare. We complain about the basics. We have more doctors, but less time with those doctors. And physician burnout is a real thing that has epidemic proportions. And I can tell you that I personally know of doctors who are burnt out and continue to practice. And these are young doctors. They're in their 30s, their 40s, never mind their 50s and 60s. So what can anyone do about it? You're launched into the world as a new graduate and you're told, okay, go out and have a wonderful career. What can you do about it? So I go back to Stephen Covey, and this has been my guiding light for most of my career. There are 3 areas in our lives that we need to think about. The very center of our lives is what we control ourselves. What can we do today in terms of the choices that we make for ourselves? The second is our circle of influence. The circle of influence are things that we potentially could do something about. OsteoBites, very good example, and the organizations that I lead, where we've got people, like-minded people, those are the people that we can have some degree of influence on. And then there's a circle of concern. The pandemic is clearly a circle of concern. We can do nothing about the way this virus is behaving. I am at home today in my dining room because we are furloughed here in Melbourne. In other words, we're sent home. We are in lockdown for another week. So this is now 2 weeks. You're not allowed to do most things that you and I would take for granted. We're talking earlier about people going away and traveling across the US. That is just a dream here in Australia. We cannot travel interstate, never mind go international. So I want to talk about the 3 areas of my life and where I've applied these principles. My areas as a medical educator, the research that I've been doing, and my clinical practice. But before I do that, I want to point out this. This is an important date. The 4th of September, 1998, Menlo Park, California, United States. That must be familiar to all people in America because that is the date, that is the birth date and the birthplace of Google. So I want to start with sometime in 1998. And the paper was subsequently published in 2002. And this is probably the most influential paper that I wrote. It's a small paper, appears in the British Journal of General Practice. And it is about my clinical practice. And it starts like this. Remember, I told you when I started my career, it started with a conversation with the nurse and then subsequently the patient about the context in which their lives, why they'd found themselves in a medical ward. Well, one day I was walking through reception and I heard my receptionist having a conversation with a patient. And the conversation went something like this. Well, Janine, I can't do anything about it. I'm sorry, there are no appointments today and there are no appointments until Friday. Can you just please give him some acetaminophen and I'll fit him in on Friday afternoon in Dr. Jiwa's clinic? And I blanched when I heard this conversation because my medical receptionist was giving medical advice without any medical qualifications to somebody with a sick child over the phone. And I said to her, Mary, why are you doing that? That's really not great because I have liability for that conversation. And she looked at me very angrily and she said, well, if you had more appointments, I would do something about it. Next time you talk to her. So I walked out feeling suitably chastised. And I went next door to my doctor colleague and I said, John, can we not have some more appointments? And he looked at me very angrily and he said, yeah, right, mate. You want to stay here all night? We have appointments booked right through to 7 o'clock this evening. I tell you what, you do my shift. So I left the room and I talked to another member of staff who said, Well, there's a seasonal pattern to these appointments. These people who want a same-day appointment, there's a seasonal pattern. There's a dip in February, and there's a dip again in August. And the rest of the year, it's fairly busy. There's a pattern. So why don't you just book your appointments in that pattern? Go and think about that. And I then went back to med school, and I talked about what interventions people were putting in place. And we came up with this one called telephone triage. And in the telephone triage, names were taken in the morning of patients who wanted a same-day appointment. And then instead of booking those people in as extras into the clinic, they were offered a telephone conversation with not a nurse, but a doctor. A doctor, your doctor, called you back and said, I hear that little Johnny is ill. Can we talk about what it is, and can we do something about it? Now that, looking back, was a very simple intervention. But instead of booking appointments, we booked telephone appointments. And it changed the way medicine was practiced, not only for the reception staff, but for the patients. And we were able to prove that this reduced workload by 40%, because as I say, there was a seasonal trend, and we were able to do some fancy maths and prove that this reduced workload for doctors. And one of the outcomes of that was we got more female doctors working for us, because they all were able to leave by 5 o'clock in the evening, when a lot of the doctors who were mums or wanted to be back at story time, bath time, whatever it happened to be, we attracted those doctors, and the rest, as they say, is history. The thing was cited by the primary care czar for the UK, and it became national policy. So from that practice, from that conversation with the receptionist, we were able to change UK NHS practice in what was known as advanced access. The next study was much more recent, and that was published a couple of years ago in the Patient Experience Journal. And it followed from an incident that happened in my practice almost about that time. So one day, by accident, I swapped chairs with my patient. Now in Australia, the doctor sits in a huge, big leather armchair, and the patient sits in a bucket seat. And the argument is the doctor is so busy all the time in the office that she needs a comfortable seat. Well, I happened to swap seats with my patient. I put my patient in the big seat, and I sat in the bucket seat. And it changed the dynamic absolutely and completely in the consultation. A lot of the patients who had that experience that day, before they left the room, asked for my card, shook my hand, did all kinds of things to express gratitude for that consultation. We then did an experiment, a simulation, where we were able to demonstrate nonverbal behaviors changed dramatically in consultations that were observed with patients sitting in what I call the big chair. It was called the big chair study, and that changed the way certainly I practice medicine. So that was something that I could do on the day. I just swapped seats with my patient. All of that was then documented in the book, The Art of Doctoring, and that was published of all years last year. So I had no chance to go out and talk about it. I just sent it all to my mates and hoped that somehow it would get wings. Now I want to talk about my work as a teacher. So as a teacher, I recognize that there are three components of how we expect doctors to practice. We expect competence. We expect doctors to know what they're doing. We expect caring. We expect them to care about patients. So we select students because of their caring attitudes. But what we don't think about is confidence. Confidence is where doctors present themselves as if they are present, as if they are mindful. Ideally, they are mindful. But doctors, like everybody else, have things happen in their lives. And so often those feelings, like being late, having a pimple on your nose, having a row with your partner, losing your credit card, those kind of things happen. And when you are in the heat of the hunt, as it were, you're going to leak that to the patient in terms of your non-verbal behaviors. So along with some colleagues, we designed a course with my colleague, Kimberly Warner, who's a film director. We created a course called Course in Clinical Confidence, dedicated to the memory of this amazing cardiologist called David Warner, Kimberly's dad, who sadly died of a car accident, but made a huge impression on his patient. He used to practice, according to Kimberly, just to be different by wearing a clown's nose on his ward rounds. An extraordinary man. So this is what we do. We create scenarios, and here's a typical scenario. This is a patient scenario. The medical students work in pairs, and one student is told, you're worried you might have lung cancer because a friend was diagnosed with lung cancer a month ago. You're losing weight, 3 kilograms in the past month. You're not on a diet and have no symptoms. You've been coughing a little for 3 days. There's no blood in your spit. You're annoyed that the doctor is running late. So that's one scenario. You, patient, are going to act out this scenario, and the doctor's not going to know what's on your mind. You're going to have to work this all out with you. The doctor is told this separately and completely blind to what's happening with the patient. Your secretary has double booked your appointments today, and there's a patient who's waiting 45 minutes. You fell on your way into work and have a very painful knee. So the doctor has to act out this scenario with a patient who could present anything. And the one that I showed you there was a patient who thought they had lung cancer. They then film that scenario, and it's filmed on an iPhone, nothing fancy. They just act it out as if it was an OSCE station. They then receive feedback, general feedback from Kimberly and I. Kimberly, from her perspective as a film director, about how she would imagine that you would leak discomfort, and from my perspective, framing the whole consultation. We don't actually see the videos. They do this in privacy. They just get this feedback, and they get a chance to score themselves on how they perform. And at the end of doing 5 such scenarios, they get a certificate of completion, a course in clinical confidence. And that currently is being used in several universities, Georgetown University and my university and several others. And we're hoping that this will become a way of teaching clinical confidence as opposed to clinical competence, where the doctor knows what they're supposed to be doing. By the way, on clinical competence, I believe we do not teach clinical competence particularly well. I spent 6 years in medical school. The first year in medical school, I was there from 8 o'clock in the morning until 5 o'clock at night. I remember those lectures. They were the lectures I got in my pre-med, first med year. None of that, 0% of that, is anything that I use in my clinical practice today. That is not a way to teach clinical competence. I'm working on a course on that. I want to now go to my research interests, and this is one of my research interests. I'm particularly interested in how we advise people with weight problems. As you know, and as I explained, increasingly more and more of us are getting fatter. And it's happening like this. Every single decade, we put a little bit more weight on. So in 2017, if your BMI was 26.2 at the age of 40, by 2022, you're likely to be well and truly overweight with a BMI of 27.8. By the time you're 50, you're going to be verging on obese. And by the time you're 55, you are going to be obese. This is a fact of life. This is how it happens. This is how we become bigger and bigger. And what happens is we don't even realize that we're getting fatter because everybody else is getting fatter alongside of us. And so we regard it as normal. And along with that, you have an increasing risk of chronic illness. Of course, it's more than just getting fatter. We're drinking more and we are more sedentary. And here is the problem. What we eat between our meals is the problem. Our snacks are equivalent to 580 calories per day. So if you think about it, the average person needs between 2,000 to 2,500 calories a day. We're consuming a huge proportion of what we should be eating as snacks. Snacking has become the new smoking. And I challenge you to go on YouTube and look at ads for snacks compared to the ads that we had for cigarettes in the 1950s, and there's a definite resonance there. You will see how we use the same techniques to sell biscuits that we did to sell cigarettes, and the lobbies that are working in the background to promote all of this consumption are as powerful as the tobacco lobby was in the 1950s. So here is my study, and this is the study we're currently doing. This is me today, right in the middle. I'm doing no exercise. If I carry on like this, in a year's time, with no snacks, I'm going to look like the picture on the right. And if I continue having snacks, by the way, I do love this coffee and cake business. I'm going to look like this in another year. And we are presenting these images to people in the workplace, and we're asking them to make a choice, and we're advising them on how they could potentially improve the outcomes so they look more like the picture on the right than on the left, if that is what they want to do. So where to from here? I would say there are, again, the three circles. Is it in my control? My behavior, my attitudes, my responses. The center, it's not in my control, but can I exert influence in my home environment, with my finances, my family, my colleagues? And there are things that we cannot influence and we have to accept, whether that's the pandemic, the effect on our economy, whatever it happens to be. I would argue that there is something we can do about the pandemic. We can all be immunized and we can all wear masks when we're out in the public and when we're amongst each other. There are things that we can do, but that brings it back into, is it in my control? There are things that are in my control that could influence that bigger picture. I surround myself with wonderful people, including the folks at OsteoBites and the wonderful Anne Graham, who are part of this community that we call the Patient and Physician Advocacy Alliance that has funded the Journal of Health Design. It is our circle of influence, and I believe it will impact the circle of concern. Thank you.
Thank you. Now I'm thinking, gosh, should we change the name from OsteoBites to Osteo Don't Snack Right Now? But that's true. You know what? I got a health tracker on my phone. And so, you have to put in what are you eating for the day? And it's true. Snacks really take you're right. It's like 500 to 600 calories a day. And I was like, oh, geez, no wonder. So, Dr. Google, what snacks are 100 calories or less? And we had on a really brilliant oncology nutritionist a few weeks ago, and there's so many questions because there's so much confusion about what to eat. What's healthy? Can I eat a banana, or am I giving myself too much sugar? Should I not have a banana? Should I eat nuts instead? Like, it's a very confusing whole situation. Okay, really valuable information. And like I said, I got some notes in here, and one of the things that really resonated with me, and I know Maeve and Mia will have an opinion about this as well, the theater model of where you doctor and where you're treated. There are real triggers in that space. For me, one of my greatest triggers is when somebody hands me gray socks with the rubbery sole. Like, I feel sick when I see them. Like, I literally feel sick, and I feel like I am sick because I'm putting on these gray socks at a mauve room and a horrible gown that is been used and washed, since the 50s. So those things really do matter because it either adds to or takes away from your own well-being and feeling well or feeling sick. I know at our junior board meetings, we've talked about this sort of thing. And another thing that's really a trigger, maybe the biggest trigger, is smells. So I know, like, Maeve, you want to talk about your triggers?
I feel like definitely there are certain smells or like colors that remind me of chemo, or particularly foods also. I feel like there are all of those things that can just definitely take you back very quickly.
Yeah. So what's the answer, Moyez, on this? Like, because I think we can do better. I mean, just paint. Like, that's not it. Just put up different paint. That's my 2 cents. That's my medical advice for doctors. Please use a different color of paint, because mauve/dusty rose is just not. It makes me sick.
Yeah, it's exactly all of that. Yeah, I think you're right. It's the environment in which we greet and expect our patients to tell us their deepest, darkest secrets, we pay no attention to the environment in which they are expected to do that. So, it's usually a dusty corridor and you can hear people outside. It's classic blue walls. The computer is pretty much takes over the whole room. The doctor has his back turned to you. His tie's probably hanging down somewhere here, or she's got, spinach in her teeth. It's all these kind of things that we do not consider in terms of how we set ourselves up. It's an act. The whole thing is an act, because if you think about it, if the biggest cause of complaints is whether we're treated with respect and how the doctor communicates, it's not just what he or she says, it's also how that is framed and how we're made to feel in that environment. And that's where the big chair seemed to resonate so much. If you put in the big chair, you put in the chair that says you are in control, you're going to feel very differently.
I actually have somewhat of a funny story about it. I remember going back to college after after my first, set of treatment, and we thought I was in the clear at the time. And I went to a party and there was a red punch being served. And I had doxorubicin, AKA the Red Devil. And I ended up getting really nervous and feeling really sick. And I hadn't had anything at that point in time. And I had to leave. And I had no idea why. I was scared I was sick until I realized the next day what it was. Also, the smell of rubbing alcohol wipes. That gets to me sometimes, and specifically the noise, like any beeping noises at certain frequencies, or even if it's in a song, I'll get really anxious. And even getting off, and it's a, through street throughout a lot of Western Los Angeles, exiting on Wilshire Boulevard, seeing that exit, I start to get nauseated because that was how I would get to the hospital for every round. So yeah, it's definitely, there's definitely a lot of stuff like that out there. And it's definitely interesting.
Yeah, those things matter. And Moyez and I have talked about this. We talked about a really good experience that I had when I was first, I hadn't even been diagnosed yet. And I was so scared. So you're scared. You think, I know I have something going on in my leg. You're scared. And then you get put in a room in a paper gown, sitting on a table. And this doctor comes in and, never once looked at me, had his back to me, was frustrated because he couldn't get my disc to work. I didn't know if he was unattending or if he was my doctor. I didn't know, he didn't introduce himself. I didn't introduce myself. He never talked to me. So we left, we left. And we found, I know I've told you this story, but what you've said and what you study really resonates with me, because I had that terrible experience. And then I went to the doctor who ended up being my orthopedic oncologist. And even though I was at Memorial Sloan Kettering Cancer Center, I think everybody knows that by now, and which you're walking in a door that says Cancer Center on it. And it's big and white and foreboding. And then you sit down with, said paper gown on the table. And in this second scenario, my doctor, whom I adore, comes in with his team around me, and I'm sitting on the table, but he came in and he's an important guy, and he looks and feels like an important guy. And I'm just like, oh God, here we go again. It's in this white place. And he takes a seat lower than me. And he puts his hand on my knee and he goes, I still get emotional when I think about it. He goes, tell me what's going on. And I started crying like this. And I couldn't talk. So my husband had to say, oh, this is what's going on, blah, blah, blah. And I know he'd seen the x-rays. He probably knew at the outset before surgery and all of that. But it was so disarming. Like, he saw me and was like, that touch was like, I'm with you. Like, I got you. And it was just so disarming. And I had like all the armor, all the walls dropped from the last experience. And I was just like, all right, what's next? Like, And I will forever be grateful and loyal to him for that moment. Like it was such a great moment and such a lesson in communication and seeing another human being. Like it's a human experience. So this, what you talk about in the book with the theater model, like even though he didn't have in that space, you have the big cancer center on the door outside, doctors walking the halls, it's very sterile and all of that, he still was able with all of that walking in to disarm me completely and know that I was being heard. It's a profound experience to feel like you're being heard, especially when you're scared. So this work, Moyez, I know we've talked about this. It's so important. And it's so important. And I really think every doctor, and especially doctors to be, need to read this book, need to have this work presented to them, because it's profound and it changes your experience from fear to confidence. He had enough confidence in his game to sit lower than me and listen to me instead of going, well, listen, I've seen your x-rays and here's what I think. We're putting you into surgery right now and blah, 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 which would just, I don't know. I think I might have passed out at that point.
Yeah, I totally get that. And, we've been in that situation. We call it the pregnant pause, where you ask somebody what's happening and you don't interrupt. Even if you know the answer, you don't interrupt. You'd be surprised what comes out of their mouth, what comes out of their deep inside them, because it's a very uncomfortable place to be when somebody asks you that question. You're almost off your guard, and yet you feel your vulnerability is being, cradled in their hands. And what happens is you say the thing that matters to you, and the catharsis is enormous, as you say. You burst into tears because you knew at that point that which you craved the most, the trust and the care of another human being, was being offered to you.
Yeah, and I knew I was in good hands. It was just such a relief, like all at once. So you called this space the greeting, the seating, and the meeting, right before you start doctoring. And I love that. I think that's so important. And then there's another part in here that really spoke to me. You were talking about Eileen Dorley, who demonstrated the value of seeing patients and young doctors within the context of their lives. And so much about this book, it's about context, right? What's the context of around the person that you can't see with each person, anticipating their needs and responding with kindness and open to practicing with humility. So this really resonated with me too. And I'll tell you this funny story. So we do, medical research conferences where osteosarcoma doctors and researchers present their research. And so we had partnered with another organization and did kind of a thought leaders conference for osteosarcoma in California. And I started the conference with a statement that I thought they might hate me for saying this, but I asked at the outset, I said, I think it's important that when you're talking about research, you're really talking about somebody's lives. You're talking about patient families' lives. And it's not just about what you're seeing sitting on the bench under a microscope. This is a human experience having the research. So if I could humbly ask you to have confidence in your data and confidence in your research, but humility at the same time with the science and with where you're going with it. And I can't remember my whole speech, but it was about confidence and humility. And the crazy thing was, I felt like I was taking a really big risk in saying those words to really the leaders in this type of cancer. I'm asking them to be humble. And I had many doctors thank me for that and say that if anything, doctoring was a lesson in humility regularly. And so, and something that we typically don't see as patients, the humility side of it. And then it became kind of a theme throughout as each speaker came up, not every speaker, but as each speaker spoke, they mentioned having humility in what they were talking about. So I love that you talk about humility in here. And one of my favorite sayings, which I've said forever, and somebody just told me that it's attributed to Confucius, which is, you don't know what you don't know. And it's such a silly thing, but it's a true thing. You don't know what you don't know. And when you're sitting down across from somebody, you have no idea what their experience is and all the things that are swirling around in their brain, in addition to what's going on in their body.
Yeah, I totally agree. And I'm going back to that very first job that I talked about in the very first paper. That paper was inspired by Eileen Dorley, because she was the nurse who would take me around the ward and say, "Doctor, you really need to have a word with so-and-so. She was really upset after a professor had given her that news. Can you, we don't really know why she's so upset." And then, of course, it would all come out that they had all this family, etc. And you're right, it's you don't know what you don't know. And that was the lesson that Eileen Dorley taught me all those years ago. The first thing is, first job, straight out of med school, you know nothing, right? You have no idea. You know in the pharmacology, but you don't know what to prescribe. And I tell the story of the very first moment I met her. This was a lesson in humility. I said to her, "Oh, sister, what can I do for you?" And she said, "Well, doctor," she says, "would you write up the antiemetics for the patients who just come out of theatre? That would be grand, doctor." So I thought, okay. So I took out the Cardex and looked at it, and I said, and I knew that the BNF, the British National Formula, was sitting in my pocket, but I thought I better, maybe the nurse knows better than that. So I said to her, "Sister, what does the professor like to use for as an antiemetic?" And she says, "Doctor, that would be Stemetil." So I started to write ST, and she saw me hesitate, and she said, EMETIL, doctor.
It's in the book.
It's in the book. And so it goes. And at the very end, having dictated the whole thing to me, she says, "The rest of it, doctor," she said, "is on your name badge." I duly signed it. But that was a fantastic lesson in humility, but also in being vulnerable and allowing yourself to be vulnerable, because she then went on to launch my career, because she inspired the paper, and the paper then inspired the next job, which was a huge job in the most competitive of residency programs.
I love that. And the other thing about your presentation that I didn't know, and I didn't hadn't read anything like this, was that people leave the doctor not understanding their diagnosis. And I think that's astonishing, first of all, but I think it's also a two-way street where when you leave a hospital or a doctor's office and all you heard was you have cancer and you can't even pronounce the name of the cancer that you've been diagnosed with, I think it's likely two-sided, right? Not understanding your diagnosis. Maybe the guy didn't explain it right, or the woman didn't explain it right. And maybe you didn't understand it because you couldn't hear anything but the word cancer. But I think if you look at the core of that conversation, that is probably where the real problem was, where you didn't feel you were heard or checked in with, or any of these things they're really important to your life, that you understand what you're facing and what you're dealing with and what your responsibilities are with regard to your diagnosis and treatment. So it really all goes back to being listened to and feel like you're being heard. It's both things. You have to be a great listener, and you have to be heard. And it has to be both ways. But in order for that to happen, I think the meeting, greeting, and seating needs to happen, because that's how you know I'm in a safe place here, and I can ask questions, and I'm not going to be made to feel stupid. And he's not going to, "Oh, time's up, I'm out." these things are so important. I'm so for this getting out there in the world and have people go through a course that brings you back to your humanity. We actually do this at MIB in a way. We have a program called Ambassador Agents, and ambassador agents are trained. They go through an 8-hour training program, and at the end of the day, this is what they learn. I should tell you what they do. They are trained to go into a hospital or into a home, or to meet somebody who has osteosarcoma. And the ambassador agent is somebody who survived osteosarcoma and their caregiver. And their job is to walk into that hospital room and give a 30-second introduction. This is who I am. I've been where you are. How can I help you? And they don't give medical advice. That's number one. Number two, the thing that is repeated over and over again is, this is not about me. This is about you. So their job really is to be a vessel for that person's suffering, for their words. And it's a hard job. And it's really hard to not jump in and say, oh my gosh, you should see my doctor, or this is what I had. Why is he treating you with that? Like, it's really hard not to do that, which is why it's a long training program. So, and I've said about this training program, which we came up with in cooperation with the Amputee Coalition, who's been doing this for a long time for people who are about to undergo amputation or a major surgery that will affect limb difference or an amputation. So we collaborated with them and then modified it for who we are and what we do. But that's a big part of the training. It's just learning to be that vessel. And it's hard. And the funny thing about it is, our feedback has been, it didn't really matter what that person said, or they go in with a tote bag of resources and gifts and things like that. It didn't matter what they said or what they gave me, that somebody showed up and said, I was where you are, gave me so much hope that I could one day do that job too. I could go forward.
As you say, Anne, it's about the circle of influence. The circle of control is what we can do in terms of our behaviors. The circle of influence is what we can do in order to make a difference. And it is very much about that, being very clear about what you can do in your situation in order to help somebody else. And it isn't necessarily that you can change the outcome. The circle of concern is much wider. Yeah,
true story. Okay, we're running out of time, but I really feel like we have burning questions that Mia and Maeve need to ask. So can you each ask one burning question? What burning questions do you have, Mia and Maeve?
Okay, our first is, what other profession would you like to attempt?
I've always been a frustrated creative. So I think I'd like to have been an architect. And I say that many times. I'd love to have been involved in something that allowed me to really get my creative juices flowing. So possibly that.
I'm going to step away from the list, actually. I have my own. I'm actually very intrigued about this. What is your guilty pleasure television show? After a long day, what do you want to watch that will just boost your mood?
What a brilliant question. It's a British television show from the 1980s called Only Fools and Horses. You won't have, unless you were British, you wouldn't know what that was, but it was about this rogue family. I lived in a council estate in somewhere in London, and the things they got up to were quite hilarious. So that's what I would watch, yes.
I love British TV. Our guilty pleasure, which is a British show called Dairy Girls. Hysterical. Such a great show. We've watched it through like 4 times, and I'm still cracking up. Okay, so we'll wrap it up by saying thank you, Dr. Jiwa. More information on this and all OsteoBites on YouTube, mibagents.org, or wherever you get your podcast. And we'll email you links after this if you registered for the session. Next week, we're going to have another excellent OsteoBites from people who know exactly how much osteosarcoma bites our junior board. There will be 4 presentations from Brandon Friedman, Maeve Smart, right there, Kara Scruvis, and Charlotte Murdoff. They will each be making a presentation on things like what is it like to be on a clinical trial, life after osteosarcoma, what I wish I would have known before treatment. It's going to be so interesting and a great discussion. And I'm thinking Dr. Jiwa approved as we are listening to the people we all set out to serve. Until then, which I really hope you show up for that, it's going to be amazing. Many thanks to our guest, Dr. Moyez Jiwa, who listens, hears, and cares greatly for his patients and the doctors that he serves and teaches. Thanks also to our junior board panelists, Maeve and Mia, who are brilliant and adorable. Thank you for joining us today, and we'll see you next week. Thanks, everybody.